Welcome to Module 11 of this course from the World Federation of Societies of Biological Psychiatry. Today we're going to discuss the efficacy of pharmacological treatments of cognitive impairment in schizophrenia. So we're going to discuss the safety and efficacy of the drugs that are being used to treat schizophrenia and to treat cognitive impairment in that condition. We're going to also discuss how to apply the knowledge from the clinical trials, what we learn from those, to treat patients in clinical practice. And finally, we're going to acknowledge the current status of drug development and how new drugs are being developed for this potential indication of cognitive impairment in schizophrenia. For that purpose, we have a distinguished speaker with us today, who is Professor Kazuyuki Nakagome, who is from Japan and who is an expert on the treatment of cognitive impairment in schizophrenia. Welcome, Professor Nakagome.
Thank you.
So, Kazuyuki, thanks for participating in this session and this interview, which is going to be informal, but dealing with very important, clinically relevant content. Let us know what is the efficacy of antipsychotics and the comparative efficacy of atypical and first-generation antipsychotics for the treatment of cognitive impairment in schizophrenia?
Well, yes. First, I want to thank you for letting me have this big talk. Well, yes, initially, the cognitive effect of atypical antipsychotic drugs was thought to be really robust. And we were really excited about it because we knew that cognitive function is closely related to social functioning. So we just expected that this atypical antipsychotic drugs may improve the social functioning of the patients with schizophrenia. Well, but however, most of the studies that showed the benefit of atypical antipsychotic drugs were using the switching method, which means switching from conventional drugs to atypical antipsychotic drugs, and they show the efficacy during the switching process. Recently, in those trials that use more strictly controlled design, like using RCT or adjustment of dosage level of antipsychotics and also the anticholinergic drugs, we found that it was not as robust as we expected it to be. In a meta-analysis study, we found that using the RCTs, we found that the effect size of the atypical antipsychotic drugs was about 0.24. And in the same meta-analysis study, taking in all those prospective investigations of atypical treatment, the effect size was only about 0.36. So considering the cognitive impairment in patients with schizophrenia, which is about 1 to 2 standard deviations below the healthy controls, we think this effect size is mild at best.
So are there differences among the atypical antipsychotics as regards to the efficacy in treating cognitive dysfunction in schizophrenia?
Well, in the same meta-analysis study, the authors found no significant difference between atypical antipsychotic drugs in overall cognition. In some domains of cognition, like vigilance and attention selection, selective attention, and word fluency, there were some differences between atypical antipsychotic drugs, but the number of studies included in the meta-analysis was very small, especially for those with quetiapine. It was less than 10. In two more recent meta-analysis studies, there were some differences between atypical antipsychotic drugs, but the results were inconsistent. In a report by Dr. Nielsen, he found that Sertindol was superior to some other atypical antipsychotic drugs and conventional drugs. But the result should be taken with care because the result was driven by only one RCT between Sertindol and haloperidol. And in another meta-analysis study, which examined longitudinal studies, they found that several atypical antipsychotic drugs were superior to amisulpride. However, as you can see, these two studies are really inconsistent. For the time being, I think there is not enough evidence to rank the atypical antipsychotic drugs for efficacy on cognition now.
So it sounds quite inconsistent as regards to efficacy. But what about safety? What about the cognitive side effects of antipsychotics?
Yes, well, the adverse effects are even more influential, maybe, than the difference in the effects between typical antipsychotic drugs. Especially, we have to take care not to use polypharmacy and using multiple drugs at once. These are the factors that harm the cognition. And also, not only the antipsychotics, but we should take care about using anticholinergic drugs as well as benzodiazepines. Of course, there are times that we need to use anticholinergic drugs to control the extrapyramidal side effects, but we may want to consider switching the antipsychotic drugs so as not to cause these extrapyramidal side effects.
Okay, but then for a clinician, how can a clinician separate what is a side effect from what is the result of the condition itself?
Well, in fact, this is very difficult. Well, most of the patients raise this question. Isn't this cognitive impairment caused by the medication? Yes, but we know that in most cases, the cognitive impairment is caused by the disease itself, because we see these cognitive impairment even in the patients off medication. But we should also take care that the adverse effects of the medication is overlapping the cognitive impairment caused by the disease. We should be very careful, and it's pretty difficult to separate them.
So as you mentioned, it is not easy to ascertain what is the true efficacy of antipsychotics on cognition in schizophrenia. But what would be the potential mechanisms involved in this potential efficacy of antipsychotics?
Okay, well, there are many hypotheses raised for the mechanisms of action of atypical antipsychotic drugs. And one of them is that atypical antipsychotic drugs enhance the dopamine release in the prefrontal cortex and activates the D1 receptor activation. Well, especially serotonin 2A antagonistic action is known to enhance the dopamine release in prefrontal cortex, and serotonin 2A antagonistic action is very specific to these atypical antipsychotic drugs. And also serotonin 1A agonists and alpha-2 adrenoreceptor blockade will also enhance the dopamine release in the prefrontal cortex. Another hypothesis is that atypical antipsychotic drugs may enhance the NMDA neurotransmission. Well, NMDA neurotransmissions is related to procognitive effects, and serotonin 2A antagonists are known to enhance the NMDA neurotransmission. It is clearly demonstrated in animal studies as well.
And then there is a third hypothesis, right, which explains why antipsychotics do better in cognitive impairment in schizophrenia.
Yes, one more hypothesis is that the atypical antipsychotic drugs may enhance activation in the acetylcholinergic receptors. Serotonin 1A agonists, as well as alpha-2 adrenoreceptor blockade, may enhance this system. And as clozapine and olanzapine do act as an antagonist to these receptors, The animal studies clearly show that these drugs enhance the release of acetylcholine in the midbrain, in the mid-prefrontal cortex, and also in the hippocampus.
So clearly there are three hypotheses, as you summarized. One is related to this atypicality of antipsychotics and the release of dopamine. The other one has to do with glutamate and NMDA pathways, and finally the cholinergic pathway. I guess this may be the foundation for the mechanism of action of newer drugs and drug development. What can you tell us about drug development in this particular indication of cognitive impairment in schizophrenia?
Well, the new drugs are developed based on these findings also. Well, for example, ensinicline, which is a selective alpha-7 nicotinic acetylcholine receptor partial agonist, and it showed a strong effect in the phase 2 trial on cognition using 319 patients with schizophrenia. And this success led them to develop, to further go on to phase 3 trials. And there were 2 6-month phase 3 trials. However, unfortunately, in these trials, there was no significant difference between ensinicline and placebo add-on. Another agent called sodium benzoate. This is a D-amino acid oxidase inhibitor, which inhibits the metabolism of D-serine and regulates modulates the glutamatergic neurotransmission. And it was pretty well in the trial to chronic schizophrenia patients. However, in a further stage, I don't know why, but the cognitive assessment was not included in the outcome measures. And another one is the tolcapone, which is a selective, potent, reversible inhibitor of catechol O methyltransferase enzyme, and is used for the treatment of Parkinson's disease. It increases the availability of dopamine in the prefrontal cortex. And now phase 3 trial is ongoing. And there are other drugs. There are new, more mechanisms of action in other drugs, like anti-inflammatory drugs, and some are working on neuropeptide hormone like oxytocin, and there are estrogen receptor blockade drugs. There are many, many more mechanisms of action in the development of new drugs.
But what you mentioned is something that happens often in psychiatry, and it's somewhat disappointing that sometimes phase 2 studies are positive and then phase 3 studies are negative. Do you think there is anything about trial design? What is going on?
Yes. Well, in 2013, Dr. Keefe wrote a paper about the study design of these drugs. Well, first of all, he mentioned about the sample size. I mean, in most studies, the sample size was not sufficient to get good statistical power to detect the difference. In fact, in 1 out of 17 completed trials available with results, only 1 out of 17 had a significant power, had enough power to detect the significant effect with a mid-size effect size of 0.5. And next, he mentioned about the reliability of the neurocognitive measures. High reliability of these measures would influence on the sample size needed also. One of the most important things that I think is the eligibility criteria to ensure that the participants have cognitive deficits. Well, we recognize that these pro-cognitive agents are not effective in all the patients, especially if their cognitive functioning is intact. So you may have to sample those patients with cognitive deficits, and you have to take care of it in the eligible criteria.
Sounds logical. You need to enrich the sample with people who are cognitively impaired to be able to prove that the drug works in cognitive impairment. Probably the problem there is that many of these trials do not have as a primary outcome cognitive impairment, right? Because otherwise it wouldn't make sense that they do these kind of methodological mistakes.
Right.
What would you, yeah, go ahead.
One other thing that I want to mention about is comes from the behavioral intervention. Cognitive remediation therapy is a psychosocial treatment for a cognitive impairment. And in those studies, it is found that the effect is strongly shown in younger patients in the early course of illness. I think it is reasonable to expect that the younger patients with greater neuroplasticity may benefit much more from pharmacological intervention as well than older patients.
That's a great point, because we actually have another module on cognitive remediation techniques in schizophrenia, and probably the trials based on pharmacological treatment should learn a lot from the design of the trials in cognitive remediation. Yes. What would be the way to improve patient outcomes? At the end of the day, what we want with all these drugs, treatments, is to improve patient outcomes. What can we do to get that?
Thank you. I think we need to combine different modalities of treatment, like pharmacological and psychosocial treatment, and presumably maybe neuromodulation techniques may become an option to be integrated into the treatment program for cognitive impairment patients. As for the pharmacological intervention, I want to mention another thing that I haven't stated before, is that we should take care that the treatment will not cause dysphoric response in patients. Well, dysphoria really hampers the motivation of the patients, and motivation is a key element to increase the benefits from psychosocial treatment, and is also a mediator between cognition and social functioning. So it transfers the improvement of cognition to well-being. I think that is one of the utmost goals for the patients and for us therapists.
So thank you very much for this great input. We've been discussing the efficacy and safety of atypical antipsychotics, whether they work as well on cognition, all the mechanisms involved, all these new drugs that may be coming, and all the mechanistic issues around how to improve cognition. How would you summarize for the readers, for the people who are listening to us, the key messages that you would like to deliver today?
Atypical antipsychotic drugs are better than conventional drugs in terms of efficacy on cognition. However, the effect size is not as robust as we expected, and there is no study that showed that atypical antipsychotic drugs may improve social functioning associated with cognitive functioning. So we still have to keep on finding and developing new drugs on various mechanisms of action, and we have to be careful about the study design, as I stated before. And right now in the clinical practice, we have some more things that we can do. So we should avoid polypharmacy. We should reduce the dosage level of anticholinergic drugs and benzodiazepines. And also we should think about combining different modalities of treatment, like psychosocial treatment, like cognitive remediation therapy. And we should be careful about their motivation. So to use the drugs that do not hamper the motivation. And most of all, we have to listen to what the patients are saying. We should look at their livings and functions, maybe more than the symptoms themselves. And the patients really want to live better and to feel happier. So I think that's the most important thing in enhancing cognition and social functioning.
Thank you very much, Dr. Nakagome, for your excellent input.
Thank you.